Good afternoon, everyone. Happy 2026, we hope. Hope everybody had peaceful holidays. So we today have an agenda that includes an agency update from the Office of Mental Health. We wanted to pick up where we left off, talking about the importance of board governance and some of the progress that the agency has made with putting some parameters around that we talked about briefly last time. We also talked about board priorities, so we have some updates there. And then open board discussion going forward. We were supposed to have a presentation from SED, but we had to change that. We'd probably have that presentation at the April board meeting instead. But let's just briefly go around this room because it's nice that some people came in person. It's very much appreciated that the room isn't so empty, not that it's really full. And then just see who's online, if you can let us know, Rachel, so that we acknowledge those folks. So I'm Courtney Burke, and I'll go this way.
Hi there, Mila Harrison with the Department of Health.
Charlie Massimo, parent advocate.
Mike Tripodi, self-advocate.
Jessica James, self-advocate.
It looks like we've moved online. Rachel Baker's here from OPWDD next to me. Thank you, Rachel. You want to just let us know who's on?
Sure. Online we have, it looks like we have Dr. Jill Pettinger from OPWDD, Kate Kaufman I see online, Kim Perry from OCFS, Sean Himes, Steve Katz, and our guest from OMH today, Christopher Smith, is on as well.
And I think you forgot me.
Kate?
Jessica James.
Oh, yeah, Jessica. Thanks, Jessica.
Great. Okay. So I sort of went over the agenda. One other item that I wanted to mention before we turn it over to a presentation from the Office of Mental Health is that the recommendation on lighting the landmarks of the colors of red, white, and gold. We sent that up to the governor's office in December. I think most of you recall that. And thanks to all the people who talked offline about this moving forward. And we would encourage everybody who's part of the task force to attend the lighting campaign and encourage, if you're involved in your community, for them to light up the colors in April with the red, white, and gold. But April 2nd, just a reminder, not that I need to remind this group, is World Autism Day. I know I saw Josh, you had sent an email around sort of weighing in about seeing if we can't have this lighting in New York City as well. That would have it would be much more noticeable than here at the Empire State Plaza. Not that we can't do both, but appreciated your thoughts on that very much.
Sorry, you also forgot me. Kristen Thatcher's here too.
Thank you, Kristen.
Hey, Kristen. Good to hear
Hi.
from you. Yeah. And again, we will have time for open discussion with the board today, but I think we're ready to move on to the presentation from the Office of Mental Health, and I believe that's a person who's online. Chris Smith, is that right? Okay. Chris, thanks for joining us today. Chris is the Associate Commissioner for Adult Services at OMH. So I'm going to turn it over to you.
Chris, you are still muted.
Sorry about that. Thank you for having me here today. I'm Chris.
Okay, so Chris, we could faintly hear you. So right, I did faintly hear him. So we're adjusting things on our end with the volume.
Let me see if I can adjust.
There we go. There we go. Now that's much better.
Yeah, thank you.
Thank you.
Sorry about that. Hopefully no more technical difficulties.
Chris, the only other note is your slides are in presentation or then in like no viewer mode instead of presentation mode.
Okay. If you're okay with that, I think I'm just going to stick with that. I've got a lot. I'm not at my own desk. I've got 3 screens going here that I'm juggling.
This works good. This looks good. Thank you.
So now it's gone from my screen. So I'm sorry about that. Let me just give me a second to figure out this going. Hold on a second. Let me see if I can share it again. And are you seeing the presentation?
You should be good to go.
Okay. Let's see. I think you can see it, but I can't. So we'll give you one more shot. Do you think you can pull it up? Because I don't know what's going on.
Yeah, we can. We just give us
I'm
a
not able to pull it up.
minute.
You know,
And if you want to just start talking while we
oh,
pull
now
them
I've
up.
got it. It's back. I have it now. Okay. So are we all on the overview of OMH's integrated care work slide?
No, we can't see it. So why don't you just give us a second in the
Yeah.
room and we'll pull the slides up for you.
Thank you.
Ready,
Can you hear me?
Chris?
Yep. Okay, great. Thank you. So let's just jump right in. If you could advance to the next slide. So I'm going to start off with just a very quick overview of some of the OMH's integrated care work. But as I was saying, you know, we've collaborated with OPWDD for many years on a number of integrated care initiatives, but we've really taken it to a new level over the last several years. Our collaboration is closer, and the joint program work we're doing, both with us, but also other state offices as well, is really dramatically expanding. So next slide, please. So I just wanted to mention a few things here. Some of these I'll talk about in more detail. But one of our longest standing integrated care services in New York State are what's called integrated outpatient services. And historically, that was between OMH, DOH, and OASIS. And it still exists. And it's a process where you could provide really formal integrated care by integrating between at least two licenses that you had. So An OMH provider who also had a DOH license could provide integrated mental health and primary care in either their mental health clinic or their health clinic. And same with Oasis. And some providers would, if you had all three of those licenses, then you would be able to provide integrated care across all three of those areas. So over the last couple of years, DOH, who is taking the lead on the development of this, has started bringing OPWDD into this framework, and work there is continuing to also be able to provide integrated developmental disability specific services. Next slide, please. Next slide. I'm going to focus on basically, what's happening within our existing system. So this is a core expectation that OMH programs are expected to be able to serve individuals with co-occurring intellectual and developmental disabilities. And this is pretty much across our system, everything from clinic level of care to our residential programs. CPEPs are our licensed psychiatric emergency programs. Again, a number of residential programs. Care coordination, transitional care programs, adult serving programs, child serving programs. However, in the reality often is that there can be functional limitations on the extent to which the individual providers can really serve co-occurring intellectual and developmental disabilities and mental health conditions, based on having staff with the expertise and familiarity with providing services. I think a lot of mental health providers don't necessarily get training in this area as part of their regular, graduate training programs. I'm a clinical psychologist. I had no training in intellectual and developmental disabilities in my graduate training. So people often have to seek it out. So that sort of staff competency limits the full scope of being able to serve people with developmental disabilities across the OMH spectrum, and I'm sure other service spectrums as well. But we're working on trying to make some changes around that. So next slide. So we have started working with a number of our programs to provide specific training so they can better serve individuals. So we're trying to close that training and familiarity gap. So a number of our service arrays can really do better by individuals with developmental disabilities and conditions. So the four focused areas that we're doing this with are inpatient psychiatric units, which have been getting training in the ASD care pathway, and our children's mental health clinics, and also our CCBHCs, which I'll talk a little bit about because those are a really interesting and new clinic model. And by children's clinics, it means our clinics that serve children. So have had training both in Spirit ID, which is an evidence-based practice, building in to a CBT, a cognitive behavioral therapy model, building in a focus on serving the unique needs of people with developmental disabilities. And also with our 988 and our mobile crisis teams. 988, as I hope you're all aware, is the federally sponsored and state-supported crisis call line, but it's also a call line for information, for resources, for referrals, and our mobile crisis teams, which go out into the community and serve people in crisis. They can be part of the CPEPs, again, those are our licensed psychiatric emergency wings, but they can also be standalone programs operated by community providers. And we had a Project Echo with those teams over the last few years, which is training them and giving them the resources to better be able to handle, manage, understand, be better able to respond to crises for people with co-occurring developmental disabilities and mental health conditions. I did want to focus on CCBHCs because they're just kind of an interesting model, and they are integrated care from their inception. This is a federal model. This is jointly licensed by both OMH and OASIS. It's predicated on having a full array of mental health and substance use addiction services. But it also, within, in addition to providing basic clinic services, psychotherapy, assessment, medication, it also provides a targeted case management and psychiatric rehab services. And there's a whole suite of 9 different services that they provide. So it's a really comprehensive treatment program. And the other thing that's interesting about it is it has a cost-based rate, which makes them more sustainable than sometimes other clinic models that rely on public funding can be. And we've been expanding these. We were one of the first states in the country to be part of the demonstration that led to the development of CCBHCs. But now we've tripled the number of CCBHCs, so we now have 39 of these. Next slide, please. So in addition to the specialization and the training that I've mentioned, we also have some programs across the state that have specific training and staffing to serve people with dual diagnoses. As you're seeing, more of these services are on the children and adolescent side than on the adult side. So as the representative of the adult side, we are continuing to look at how we can expand this focus throughout our system as well. But on the adult side, we have community residences. Those are very intensive, community living situations for people. So we have 180 beds across the state for that program. At Kings County, in Kings County Hospital in Brooklyn, we have an inpatient service, the inpatient psychiatric service that has special services and training to work with people, again, with a co-occurring population. And they also have a step-down program so for people leaving that program who need a little bit more or maybe a lot more stabilization in the community can go into that program, which I'll talk about in a minute. We've expanded more statewide. On the child and adolescent side, we have another inpatient unit in Syracuse, on Long Island. We have an intensive day treatment program for kids. We have an RTF in the downstate area, as well as children's community residence. And also, this is an important program kind of focusing on the crisis services. There are a number of home-based crisis intervention teams that go into the homes and work with families while their child is in crisis. Next slide, please. So as I mentioned, this is the program that based on the model in Brooklyn, we have now expanded this program across the state. Next slide, please. So there are now 5 of these 5 new programs, so there's 6 total. They're in each of the OMH region except for Western New York. We didn't get an applicant in Western New York. We RFP'd that. So now there's 2 in New York City, 2 in the Central New York region, and then 1 on Long Island and 1 in the Hudson River region. And these programs are really intended to work with people who are in unstable community settings. And there's a lot of reasons why people are and who are also utilizing a lot of acute care settings. So going into the hospital, going into emergency rooms. And the reason that this cycle continues is often there's misdiagnosis, the settings that they're in aren't able to meet their needs, provider skills, as we've discussed, and other. Next slide, please. So what we've started to identify is these enhanced step-down programs can really break that cycle of moving from the unstable community setting and reduce the high utilization, really sort of get to know the person, figure out what their needs are, help stabilize them, and then move them into a more stable community. Next slide. So these programs are for adults, 18 and older, young adults and adults. They have to have an IDD diagnosis or a suspected diagnosis. They have to currently be in an inpatient or emergency room. And in order to be able to be admitted to the ESD, they have to be stable and no longer requiring hospital care. So this is helpful to the hospitals because, you know, sometimes people are waiting for a very long time in hospitals for a disposition to be ready for them. And so this program provides a transitional setting where they can continue with their recovery and then be better able to move into community settings. So what the ESDs do is they evaluate and address barriers to community tenure. They do a lot of assessment and evaluation. There's a lot of care management, linkage to housing and other services. But there's also a lot of services happening in the program. Positive behavioral support, non-judgmental planning, engagement, addressing immediate needs, et cetera. And next slide, please. What's interesting about these programs is they're really two sort of components that are put together. One is a CTI team, a critical time intervention team. And critical time intervention is an evidence-based practice in the mental health system. And it really focuses on a critical transition that a person's going through. So for people on these teams now, it's somebody leaving a hospital or being in a unstable housing situation or residential situation that's not meeting their needs. So CTI teams are phase-based. They start out working very intensively, getting to know the person, understand their problems, their concerns, what are their challenges, and starting to really kind of put together a plan to support the person, really providing very intensive work up front and then kind of fading out of the background, helping the person get into the next level of care, and then providing that ongoing support, but kind of continuing to step down over time until the person's solidly in their new. Next slide, please. So now there's a somewhat different model here for how we're implementing the CTI within these enhanced step-down programs. There's a lot of focus, as I've mentioned before, on clarifying diagnoses. There's also a lot of provision of psychiatric consultation on medication management, which is not a typical CTI function, but it's really one of the key needs here. And then also, not different from standard CTI, is offering short-term counseling and psychotherapy services. Next slide, please. And so then they're also, while they're being served by these CTI teams, they're also in a transitional residence setting, which is a small 5-bed program that's a more alternative to more restrictive settings. It provides short-term stabilization and ongoing assessment of needs and support. Short-term does mean 6 to 12 months. It can be longer as needed. But the focus really is on getting the person in the best shape and understanding what they need and what resources are available in the community to get them in a viable. Next slide. So just a little bit about how the operation, the residential settings function. There are 5 private single occupancy bedrooms, single occupancy bathrooms. they have a really pleasant, as home-like as possible, living space with kitchen and dining on site, and really focused on facilitating skill building, group activities, and recreational opportunities. Next slide. I've covered this already, where they're located. Next slide. So the next program I want to talk about is similar to the ESD program. It's putting the same components together, but this is serving children, youth, and families. So next slide, please. So these programs, again, they put together a CTI team and have a transitional residential setting, but they're focused on the 11 to 17-year-old population of young children who are boarding in hospital settings. Now, on the adult side, the ESDs are specific to people with a co-occurring developmental disease. On the kids side, they're not limited to people with those comorbidities, but that's often who ends up being admitted to the programs, just because, as we all know, that the need for these kinds of transitional services, the propensity for people to get stuck, for kids to get stuck in emergency rooms and inpatient settings without immediate proper placement. So even though they're not limited to IDD individuals, that is the bulk of the people who were. Next slide. So the eligibility here, again, youth who are 11 to 17. If they turn 18 while they're there, they can continue to be served until 19. And then also their families and caregivers are served. So it's youth with mental health conditions, co-occurring substance use, medical, and intellectual development. And they're really focused on people who are boarding in emergency rooms, CPEPs, and on inpatient psychiatric units or pediatric units who were cleared for discharge but that haven't been able to find the best setting. Next slide. And then the next program, also a children's program, is a residential treatment facility. Next slide. So RTFs are OMH licensed treatment facilities that provide time-limited subacute psychiatric inpatient level of care, but in a residential campus setting. So you're getting the same level of care that you would get in the hospital, but you're in the community. This includes medical and clinical intervention supervision. Length of stay varies from 4 to 12 months. And the length of stay is variable depending on the characteristics of the person that they're being served there. And it's not a permanent or a long-term. Next slide. So within these programs, it's a subset of the larger RTF programs. So it's for individuals, for youth who are eligible for OPWDD and OPWDD waiver services. The 12-bed program, again, focused on adolescents 12 to 17. So they live in the program while they're there for the temporary period. It's, again, multidisciplinary team approach with really specific, personalized care for each young person. There's a very rich staffing pattern, behavioral support technicians, social workers, special education teachers, nurses, therapists, vocational, and transition specialists. And it, focuses on a broader array of services, arts, music, and other activities, and with a strong emphasis on functional life skills and pre-vocational skills. Next slide. And then the last, I believe, are the home-based crisis intervention services, as I mentioned. So these are in-home crisis services for adolescents and children. They provide provide individualized and family-driven care to individuals between 5 to 21. So they support families with a child or adolescent experiences psychiatric crisis, including suicidal thoughts, aggressive outbursts, school avoidance, self-injurious behavior. The referrals can come from any provider. So there's quick response, typically within 2 business days of referral, and then they provide around-the-clock support for the youth. And it's usually service provision for about 4 to 6 weeks. And home-based crisis intervention is in 55 counties throughout the state, with work underway to cover the remaining. This slide isn't totally up to date, so we may already have the full coverage, but sure. Next slide, please. So we have some specialized HBCI teams, again, focusing on working with dually diagnosed children in partnership with OPWDD. These programs are available to children with and without OPWDD eligibility and regardless of insurance. The teams have specialized training in working with the population and a higher ratio of supervisor to interventionist teams too. And they have a longer expected treatment. Next slide. So we have a few other clinic initiatives that I want to mention as well. So clinic is really sort of the bread and butter of the mental health system. This is serves the largest number of people. So we're working to enhance the training for these programs. I already mentioned within our CCBHCs, there's a cohort of staff being trained to serve individuals with developmental disabilities. We also worked with OPWDD, and we issued an RFI, a request for information, to try and better understand the needs across the state for these services and get thoughts from the community about how to better meet them. So we're still working together to process that data and see how it can impact our future. So we're, again, all 4 state agencies impacted here are focusing on looking at how to improve integrated and collaborative care across these areas. And we're looking at things like, more structural things like, this is complex work that requires special training, as we've talked about. So, can we have better rates or different rates to better support the cost of this care for the complex population? Next slide. So that's where we're at right now. I'm happy to take any questions anybody has.
Great. Thank you, Chris. I actually did have some questions and maybe a suggestion. Thank you again. It's impressive. I don't want to call it a patchwork. It's a very rich patchwork, but it's interesting how these programs get designed for specific ages or specific situations or specific settings and different purposes. So appreciate all of what you presented today. There was a couple that I'm not familiar with that I hadn't heard of before, the credit program and the on-track program, and I'll look those up on my own, but I think the ones that you went over today were really important ones. I think my thought or suggestion is that because you said that this is not something that you've typically been trained on, even given your clinical background, it would be really great if the agencies could coordinate a common credential so that it doesn't matter if you're working in the OMH system or OPWDD or foster care, that you get the credential to be familiar with the various programs, to understand what's available and types of treatment to support people who have varied needs that I think show up in all these different systems. So that was just my one thought. I know there's credentials that sometimes are specific to agencies, but it would be great for the workforce if they didn't have to go to each agency to get a different credential. going forward. So I guess my question for you is there anything you think that this task force can do to support the work that you're doing? Is there a recommendation we can add into a future report or some way we can help publicize these programs more? Because I know from my day work that a lot of different providers don't even know about these programs, and they should know. So hospitals, for example, some are more familiar than others, but they don't always know what's available in their region, and they don't always have the connections that they need to understand the full spectrum of what's available to them. I think probably even in OPWDD, there's some providers who don't know about the full range of programs that are largely OMH sponsored and funded. So I'll pause there because that was give you an opportunity to answer the question.
The credential is an interesting idea. I mean, I think we've been focusing on workforce development in a more robust way, catching up with OPWDD, who's in Oasis, who were sort of further ahead with us on some of those areas. And I'm since we're new at it, I'm not sure to the extent to which we have integrated this within that work, but I work closely and kind of on like a consultative basis with our workforce team, so I will talk to them about that. But as far as the information, we could definitely do better about informing the community about these, even through. I mean, we do have our Find a Program site on our webpage, but I'm not sure how. I'll follow up and look and see if it even actually captures this different population. I'm not 100% certain that it does. I haven't looked in a while, but I think I think it would make sense, given that it's not thousands of programs. We might want to also consider like including it as a specific resource on our webpage and keeping it updated. So I think you're raising a very good point about that. But the on the ground resources are both our field offices, the OMH field offices, with 5 field offices, but also the county directors of community services. So I think those are the really the closer to the ground resources that you can also reach out to for information about these services.
That's
And we need to make sure that our DCSs are, I mean, they should be aware because they're, responsible for their entire, all the programs in the counties across all of our service arrays. But we can share these, we will share these resources with them in the same way that I'm talking about here and make sure that they have it at their fingertips.
Great. Thank you. Are there other questions or comments? Charlie.
Chris, thanks so much for that presentation. I do have a question though. As Courtney said, you break up the groups or segment the groups and the locations. But it seems like all adults are lumped into just adults. What happens as this population continues to get older and older, and the needs of, I think, the mental needs of people that are over 60 versus under 60 become much different, I think, not having any validation to that. And in nursing home settings, which I think a large part of the population has no idea how to deal with it when they're in the nursing home setting. What's the department doing to think about that and to look forward at that population, our population, as it continues to grow and the needs change?
Yeah. We're working on, those are very good questions. And nursing homes are, I mean, it's sad when state agencies answer these questions in this way, but it's the truth. The nursing homes are our Department of Health program. So we do collaborate with them on and we have initiatives that are trying to get underway to improve just general mental health work within nursing homes. So I mean, I think that would. I don't know how nursing, I can't speak to how nursing homes handle or work well or with people with developmental disabilities. But as we develop those continue to develop the mental health programs, we'll need to make sure that we're taking into account the needs of the mental health needs of older adults with a developmental.
Yes, I had a question. First and foremost, I want to thank you for coming on and sharing this proposal. This is something that's very near and dear to me as a person who's been institutionalized twice in my 20s for suicidal ideations and being a person on the autism spectrum. I like the idea, I like the proposal, but the thing I'm concerned about is the children that are in inpatient facilities. They have restraints, and I've heard some horror stories, and I was taking a student mental health certificate last year and came across some real case scenarios of children who are on the autism spectrum who died from staying unattended in a restraint chair or some restraints for a long period of time, and they had stopped breathing, but either the teacher's aide or the staff, whoever they were under the care of, were just neglecting them, or they were just saying that, or they were doing that for attention. But by the time they were trying to aid this person or wake the kid up, it was too late. What is going to happen to prevent that from happening? That's the thing I'm concerned about, are deadly restraints.
Yeah, that is a concern. And within OMH settings, we have very strict protocols for the amount of time people can be in restraints, that they have to be closely monitored at all times. Because yeah, I mean that is it's a risky. There are risks associated with using those types of interventions. And so we have very strict protocols and expectations, which we monitor closely in the settings where those are used. On the OMH side, they're mostly used in hospital settings. So they have to be ordered by a doctor. There have to be people who are observing. People are taken out as soon as they're as soon as possible.
Because
Really
still in 2026, people are still being left unattended, and because of the negligence of these healthcare professionals, they're losing their lives, and they're being treated like they're homicidal and they're criminals.
Yes, it is a concern that we do our best to. I'm not familiar with statistics of people in our system who are dying in these situations, but but again, we have protocols in place that we monitor closely the providers who do these to keep people safe and try and use it as sparingly as possible.
Great question. Thank you. Kate, I think you're next up on the queue for your question.
Hi, yes, I had a couple of questions. My first question is, how are you bringing lived experience, those with lived experience, and to help inform what you guys are doing at OMH, especially around these co-occurring conditions when we're talking about like mental health and autism spectrum disorder?
Mm-hmm.
And
So,
then the other question I have is about the types of training that you're providing staff and what the foundation of those trainings are. I don't recognize what you mentioned, but I did see where it mentioned positive behavioral supports. And I just want to ask if there is any if you guys are doing any work around using developmental and relational models like DIR floor time and a trauma-informed approach, because a lot of those behavioral approaches, because of the nature of the nervous system of a person that's autistic, a lot of those behavioral approaches are not effective or cause more trauma and or are approaches that have been used in the past. So they can be very, especially those who have experienced ABA. Those behavioral approaches can be very triggering in those settings as adults. So I'm just wondering if you guys, if you take those things into consideration, or what kinds of things that you're doing to ensure that people's mental health is being protected.
Thank you. I'll do my best to answer the second one, but the first question about people with lived experience, we have incorporated peer services in many of the programs that we talked about, that I mentioned, and it's on our side, it tends to be people with a lived experience of mental health or substance use conditions, but it certainly I'm aware of a number of peers in our system who also have recurring mental health and developmental disabilities. Again, I think it's a good thing to kind of keep in mind with our workforce initiatives and also with our peer. We have a team, our Office of Advocacy and Peer Services, who's really focused on that, and I'll check in with them and bring that up to get a sense of where they're going, what their focus is on developing that co-occurring peer workforce. I'm not an expert in the training, or as I said, humbly, or the services or developmental disability system services. So I can't speak specifically to a lot of your service questions. I don't think those tend to get used in the same way in many of our systems. They're more mental health focused, and so it's people with mental health conditions and developmental disabilities. So other than, again, like, for some of the more restrictive services and restraints, those tend to be limited to more like our inpatient services. We do do our best to ensure that all of our service arrays have a trauma and approach.
And thank you for that. And the last question, I believe, is from Chris Tasato.
Yes, thank you so much for the presentation. Very informative, and appreciate OMH and OPWD's efforts to expand services for duly diagnosed individuals. I just had a question related to, OMH historically has had like admission and eligibility requirements for residential and inpatient programs that often include IQ requirements, being like an IQ of 70 or above. So given the expansion of services for individuals that are duly diagnosed, are there any efforts to make changes programmatically and perhaps from a regulatory perspective to be able to accommodate the changes in these programs? I'm like even thinking about like the SPOA applications and the CSPOA applications. So are the referral processes going to be the same or different? And are you planning to implement some changes in the practices to access these services?
Yep. That's a really good question, and I don't think we capture. I don't think we have those criteria in our regulations at this point. I can't think of anywhere we include that. But then how things are implemented on the ground with SPOAs and other systems, individual providers, it definitely is. To have that would be contrary to what I'm describing as our focus on being able to serve the co-occurring population more broadly. So I certainly don't think we're doing those across the board, but there may still be systems, programs throughout the state that have those. So I'll have to follow up. I think that's a really good question that we want to make sure, we're that following what we're saying, right? That if we're actually putting out that we're working with people with co-occurring disorders, we're eliminating the barriers to do that. So I thank you for raising that, and I will follow up and make sure that we are not doing that, because that was a very good observation that is contradictory if we are. So thank you for that.
Great. I think that's all the questions in the queue. So Chris, we really appreciate this presentation. I would say keep up the great work, you and the other agencies who are rolling out these programs, and whatever we can do to be helpful to highlight how successful they are, or to communicate to more people that these programs are available. Just let us know.
Yeah.
Thank you.
And we might want to have a meeting sometime and talk about how we can collect.
Absolutely. Yeah. Yeah. And look forward to hearing about the results of, how they're doing, since some of them are pretty new, I know.
Yep.
It's great. Thank you.
Thank you. Bye-bye.
Bye-bye. Okay. Great. So before we get into a discussion of the board's priorities, we did talk about governance last time, and I think I'm turning it over probably to you, Rachel, to talk about the work on that.
Thank you, Courtney. This is just a really quick update, just a reminder for everyone that we are working on drafting bylaws, which will outline how the board operates and makes decisions, a code of conduct, which outlines expected standards of conduct for board members, and a conflict of interest policy, which includes information on when a board member should and should not be involved in a discussion or vote, amongst other things. We're still working on them. I just wanted to give an update that we haven't forgot about it since the last meeting in November. There just hasn't been that much time since November. The goal is to have a draft available to all the members to review in advance of the April meeting, so we can discuss it in April, talk through any questions that people have, and if everyone agrees with them, we can vote on them and get them enacted. So that's my very brief update today.
Great. Thank you. Appreciate that work. And it would be great to have something more formal that we can adopt in the maybe a April meeting. So for the next part of the agenda, I'm going to go through some slides, right? Is that me? Okay. That are related to the board.
I just had a quick question about what Rachel just said. Is that okay?
Yeah.
Absolutely, please.
That's Kate. I'm just wondering who's working on those bylaws.
So right now it's OPW staff who are drafting them, but they are going to go to the full board council for review, edits, questions. We're just doing the first draft.
Do you have anybody with lived experience working with you on that first draft?
Not the initial draft, Kate, but that's why it's going to go to the full board.
All right. That's why but I want to be mindful that nothing about us without us starts at the very beginning. So that when we start doing those things without the voices at the table, like that's the first. So I just want to be mindful of that, and we can move on. Thank you.
Thank you, Kate.
Great input. Thank you, Kate. All right. So some of you have, you've joined the board at various points. So I think just to do some level setting about how this board came about and really how our original charge was in the legislation. Then I'll talk about the board priorities that we have talked about. I'll talk about a survey that we did to determine what did we think are the most important things. And then we'll talk about each one of those individually. So it should be a pretty robust discussion. So just as a reminder, this slide talks about the legislative mandate, which is to study and review effectiveness of supports and services, is charge number 1. The second is identify legislative and regulatory activity needed to improve supports and services. So certainly, I would say administrative activity as well, because a lot of what was just talked about are programs that may have been established in legislation or regulations, but are also ones that require a lot of administrative actions to implement. Improve interagency coordination, and we're doing all we can to encourage things like we just saw, and improve outreach and coordination for minority groups, and then other matters deemed appropriate for the board. So it's a broad mandate. So when the board met, we had come up with a report, And we've periodically returned to that report of what was recommended. We've updated it. We've occasionally had focus groups to look at specific areas like housing, for example. So, so let me talk about some of the board priorities. So we started with what we would call a priority setting exercise where we identified a set of priorities. And we did that through a survey of board members. And so today we'll use the results of the survey as a starting point for the discussion. So if we could go, I think there's a summary slide that show the preliminary results from the survey. Okay, so here they are. So you can easily see, I like this visual, where we landed in terms of number of votes. So you see access to services, housing, employment are the top vote getters, and then health and wellness and cross systems collaboration. So we will talk about those 5 today. And before I go to the next slide, I just wanted to note there were some other areas that are up there, workforce, which is definitely, it's definitely a priority. I hear about it all the time. Sometimes when you ask people, what are your top 3 priorities? They say workforce, workforce, and workforce. But I think from individuals, those with lived experience, in terms of what are their priorities, number 1 is the access to services, housing, and employment issues. So given that frame, why don't we go to the next?
Courtney, can I just ask you a question?
Yeah,
Is
sure.
there a distinguishing, is it distinguished between when we talk about self-direction versus certified, or it all lumps in as one?
It's all lumped in as one. Yeah. Yeah, I mean, if you think we should be
Well, because I think,
pulling those.
because I think things in certified are much more restrictive. You don't have as much say, although one of the things I like to push is having more say in certified housing
Yep.
versus self-direction. You have a lot more say. So I think what can be accomplished is very different on one side versus the other.
Yeah, it's a great point. I'm wondering how we incorporate that into what we might talk about today. I agree. I completely agree with what you're saying, Charlie, of allowing more self-direction generally across the board, regardless of setting or program.
Holly, it's Jessica James.
Go ahead, Jessica.
I also had a question on when you talk about direct care and workforce, do you mean like, by accommodations in the workplace?
Yeah, no, it's a great point. Do you want to?
Yeah, that's a great point, Jessica. I think what you're talking about probably would fit in the employment category more, right? Like, so if you are seeking employment, what are the accommodations that you're getting in the workplace to be able to be successfully employed? What are the supports that are allowing you to be successful? The workforce is more for someone that needs direct support. So that's a little different. Does that make sense?
Yeah, because right now I'm actually in the early planning stages of planning my own business. I'm actually it's I actually have a name for it, but I still have to get the LLC and I have to get the website, and I'm about to have 2 focus groups this January for more information. The first phase of this staffing initiative is to establish a magazine, and most of the jobs are either going to be hybrid or completely remote, because a lot of my job seekers or my candidates may have chronic illness and they still want to work, but they can't work in the office. It's just impossible for them to work with a chronic illness that's constantly taking them to and from the ER in the hospital, and they still want to work.
Yeah, Jessica, I think that fits perfectly into the employment conversation.
I mean, like, if this was the wrong conversation, then
But I think we're 3 slides away from that one, so we'll get there.
Yeah. Okay. No, appreciate that. So why don't we start with access to services and some discussion questions here, just to delve a little deeper into this particular area. What services are you interested in, or in terms of access? So, because access is such a broad category, what would the vision look like if access to services were different? What does access actually mean to you? And are there other people that we want to hear from? So Mike, I saw you got your hand up.
I put this as my priority. Because I'll be honest, I have no idea what these services are. I've been on this board since almost the beginning. There's not an easily navigatable way. And these presentations are great, but I just see alphabet soup. That's all that presentation was to me. We need better access. We need better understand. We need easy, accessible access. And we need people who are able to help people navigate. Like we need somebody to be that guide. We need to have, and I think big aware. The thing I was going to say before this was awareness and acceptance is something that, I'll be honest, it shouldn't be its own thing. It's kind of baked into everything here because that's the underlying, having that awareness, that acceptance drives everything else. But the big thing is that, like, I don't know how to navigate this stuff, and I can't imagine somebody who, uses alternative communication methods. Somebody, I'll be honest, I have means, I have privilege. It's easy for me to kind of strike it out on my own. But I also have an 85-year-old father who helps me navigate it, and he's not in the best health. So I don't know what's going to be next. And I'm an only child. My mother's passed away. So I don't know how to access these services. I don't know what's available to me. And there's no easy way to navigate this.
Yeah, I
as-
really
as people
like,
age.
Thank you, Mike. Is this Kate? As someone else who's autistic and trying to navigate these systems, not only myself, but as a special education teacher, I also am unable to navigate these systems. My families are unable to navigate these systems. I have a 10-year-old boy that I see who needs help and assistance pulling up his pants, and he's non-speaking, and he somehow was denied self-direction.
yeah, thanks for,
I lose sleep over this every day for myself, for my family. And this is why it's so important that people with lived experience sit at the very beginning of all of these conversations. Because we can't navigate these systems when we're even working in them. When we're sitting here on the board, I have no idea.
yeah, Kate,
And it's heartbreaking for me. I literally lose sleep over it at night about the families that I'm trying to serve that have that are trying to work 2 and 3 jobs. They're trying to take care of their kids, however many kids they have, and they're trying to access and navigate systems with care coordinators that are changed like underpants.
Yeah, Kate, no, I appreciate your examples and the lived experience. Same thing, Mike. And just a general comment on that, if in the regular Medicaid program for somebody who's just trying to get eligibility and then potentially move on to more enhanced services, there are navigators. That's a designated title of positions in regular Medicaid, and there are care coordinators in the OPWDD system, but then just the navigation of when you first enter the system and being in the system would be something that we could make as a recommendation going forward. And I would add to the term of more navigation, more transparency of where you are. I think that would help with access, because a parent may, you wait a fair amount of time sometimes to know that you're eligible, but then that doesn't necessarily mean that you've been approved for access to a variety of services. And if there were more transparency for parents or self-advocates and they knew how long is it going to be before it's likely that I'll have an eligibility determination, and how long would it be until I can get approval to access these types of services, I think it would reduce anxiety, because when you have no idea and you're waiting for months, you start to worry, have I been lost altogether? What's going on? So transparency. I know the commissioner's been trying to work on that, but we're supportive of her work in that area. Any other thoughts, comments on the area of access to services?
I do. I raised my hand, but I don't know. Anyway, I think we should have like a system that, like, I don't know. I agree with Mike about like making systems easier. Maybe we can make a website of what services are there, because I didn't know there were so many mental health places that can help with mental health. I mean, I think it's struggling to know what we can have, and like we have to go through hoops to figure out what services we need, and to understand what we need, because it is struggling to figure out what services will help you better, or what services are out there for everybody, if that makes sense.
Yes, absolutely. Absolutely. Yep.
And to that point, because it not only has to be the level of service has to be by region, right? Because it's very different from region to region, what services are available and how to access them. And that's very confusing on the site. So I don't know who develops the website, but it does appear that website needs a huge overhaul. And it needs an overhaul from and I don't know who originally did it for OPWDD, but it almost seems like it needs an overhaul from someone on the outside to come in and look at it as if they were a parent or as if they were Mike, and say, hey, and give them a task, find this. All right. How long did it take them to find it? Was it accurate? Because the other thing, a lot of the information online is not accurate on the website. It's just not
I
accurate,
agree.
or it's outdated. And that's a major problem. So I think an initiative should be someone should redo that website from a professional standpoint, not from OPWD. And I don't mean this, but trying to save money. But really do it the right way so it's meaningful to all those consumers that are going to the website to try to find information.
Yeah, that website is very confusing. I even went on it and to try to find stuff, and I couldn't even get any information, or they're just mixed everywhere, and that's really difficult, especially for somebody with autism or a parent with a disability, disability children or an adult or a teen, to get the information they need to get the services. And I agree with you.
Yeah, I'll volunteer to help with that, because yeah, I could do it. I would love to help with the analysis of that. Also, I want to add that we also have to make sure that we add in the dimension of first responders, people on the streets, because that's one of the big things that I think is missing, is like when I was riding the ambulance, or like when I'm out, I'll be honest, I know more resources in Kentucky than in New York around this. So when I'm working with somebody who's going through a crisis situation, and I can say, hey, by the way, oh, I see that, you said that your child has been diagnosed with autism. Here are some resources. Here's an intake that I could get you into. Like, I know more about other states than New York. Granted, I haven't ridden an ambulance in New York in 5 years, but that's something that if we could have an easily accessible thing to get out into the street, like an app, actually, if we could have like an app or something that, here's a QR code, scan this, now it's on your phone and it can help you navigate.
Yeah, and I appreciate that. And Mike, Gilberg and Steve Katz, I know that your hands are raised, but just to on your point, understanding how people access information now, because that has changed dramatically over the years. A lot of people, honestly, a lot of people don't go to websites as much anymore. There's social media, but I think about the 988, how effective I think the communication has been about the 988 hotline in mental health, and how it's everywhere. And if there were something that whether it is a QR code or something like that, thinking creatively. Yeah.
And actually, we had a lot of success with that in Kentucky with, so we had the number, you could text a number or call a number or do the QR code. And we were able to effectively do that. Like, I was literally in the mountains in Kentucky with somebody who has never touched a computer and didn't have a cell phone, and was still able to get them the services that they needed between using those three different but it took us sitting down with them on their front porch and actually going through it with them.
Yeah.
So that's the other piece of it is.
No, that's great. That's great. Thanks. All right. So we're going to go to folks who are online. So why don't we go to Michael first?
Can you hear me?
Yes.
Sorry, I'm not there in person today. It just didn't work out. Um, I agree with what Mike and Kate said. Even as a lawyer on the spectrum, I can't figure out a lot of these systems. And again, I went to law school. I'm an admitted attorney, and I can't make sense of OPWDD. People ask me questions, and my eyes glaze over. And you would think with a law degree, I would be able to figure it out.
Yep. Yep. So simplification. I mean, because it is a lot of information, but because the number one question is, how do I get access to what I need? And
And then making sure that information is accurate. I mean, I've been in business since 2023, and the agency here that supposedly collects that information and puts it out to the public still hasn't included me in their publication. So making sure that the supports that are out there for families, that they can access the supports, those things, those lists need to be updated. I mean, even the OPWDD site isn't updated. Those things need to be updated with the proper agencies that are out there and available.
great. Okay. Steve, you've been very patient. You want to go?
Yes, I think my concern is that somehow streamlining the process of getting approved for OPWDD services in the first place, and then all the steps. I mean, it's not months, it's years, literally years to get into self-direction. I did it. It took a very long time, but you know, I'm a really good self-advocate, and I have family that were advocating as well. It's just a way too long of a process. And the other issue, which I've mentioned before, is, you know, because of cuts to Medicaid and Medicaid offices and customer service, it literally takes days and days of sitting on the phone, on hold on the phone for hours to get a hold of Medicaid. Mail is not going out. I have not received any mail from Medicaid in at least 6 months.
That's good feedback. Thank you, Steve. Any other comments before we move on to housing? These were all really good suggestions about navigation, transparency, faster process approvals, simplification of the information, whether it's a website or a QR code, getting first responders information as well. And then we had Mike, you volunteered to help with how we rethink the approach in the communication. So thanks. All right. So housing, we'll move on to that slide. A very big topic area. So a couple questions here. What aspects of housing are you interested in? Charles, I know earlier you sort of brought up the certified, non-certified, formal, informal. What's your vision for this area? Are there people you want to hear from? So housing, what comes to mind? Any comments or thoughts?
I have a comment. I think yes, we have a lot of group homes, but we don't have a lot of independent living who can live on their own and or have people struggling or landlords do not want them in their housing because they don't believe that a person with disabilities can't handle it. Yes, they might need support, a little support, but most times they can do it, but with some help. So I think we need to work on getting more independent living situation for people who doesn't need group homes.
Okay. Yep. Thank you for that.
Kristen, I had a question about your more so independent living. When you talk about that, are you talking about those IRA type housing situations?
No, I'm talking about like living on your own, no IRA. Because some people don't even need that. I'm not saying everybody, but some people just don't need that either. They can live on their own, but with like self-direction, people coming in, their staff coming in and helping them live independently as possible.
Okay,
That's
gotcha.
what I'm saying.
Okay, gotcha. I did also want to um put in my 2 cents. Right now, I'm living in a housing situation that's just not the best environment for me health wise, because I live next door to a neighbor who smokes like a chimney, and every night when I'm trying to sleep I can smell the stench of tobacco smoke coming from the vent from her bedroom to my bedroom, because her bedroom is back to back with my bedroom, and that causes me to have asthma. The housing that what they need to do with housing is they need to make it smoke free, because there might be people who have severe respiratory problems, people who might need a CPAP, to sleep during the night, or in and if that tobacco gets under the vent from the bedroom that's back to back to the person's bedroom, that could cause huge problems. Or what if this person's on oxygen? And also right now the problems I'm dealing with is my updated housing subsidy. It's still being it still has not been, it hasn't gone through yet. I haven't received any payments. It was updated, but like, it's been we're like in the 7th day of the new year, and I'm still having trouble getting my housing subsidy, and my landlord keeps on harassing me. And I've been having to go back and forth between my landlord and my care manager about what's been going on. And to make matters worse, a couple of weeks ago when I was at my local um Department of Social Services office, I was denied any help for helping with back rent, because my social security had exceeded what I qualified for.
Yeah, I think housing is an area that we could spend hours on. Because it is the biggest need, and I think that's one area that this committee can have a huge impact on the lives of individuals impacted by autism. But I think one thing is OPWDD has to loosen up their restrictions on how they view housing. I visited places, now the new one in Virginia Beach. I visited New Jersey. I visited my first place in Arizona. I visited Florida. I visited all these communities that are intentional communities that are thriving and doing amazing work. Yet OPWDD in the state of New York does not view intentional housing as a legitimate solution. It's probably one of the most legitimate solutions for economic reasons, for safety reasons, for so many different reasons. Yet OPWD still is very close. I'm not going to say close-minded, but they view it very differently than every other state for intentional living. And that has to change if we want to make any impact or dent on housing in New York.
Also, that can all if that even like with definitely with OWDD doing that, that makes it sound like they want us to put us back in an institutionalized, but we shouldn't be, as like people living on their own can actually do great in the community, not being locked up, not really locked up, but you know what I mean, like hold in one place. And everybody should be allowed to be in the community, enjoying life to the fullest.
Yes.
So I think we need to really work with OWDD to realize that independent living and housing is more important than like other things, not everything, but I was mean like to to like if they want us independently, why are we not living like independently if we can? That's my full question. I think the state needs to really work and work on to make sure that the government actually do something with making sure our money gets there when we need it.
That's very contradictory, but my issue is more so with the Department of Social Services. They didn't give me any support to help with defray my back rent that I owe with my apartment because I had other bills. I have to pay for my internet, I have to pay for my cell phone. Social Security, you can only get so much, and like so my question is, how do we, as the OPW committee, work with Department of Social Services? Or how can we collaborate?
That's the problem. That's the problem we're having. Like, that's exactly what I'm saying. I am saying that OWDD should like really look at um living in the community than group homes if you don't need a group home, if that makes sense. And really work together to give us the money that we need so we don't get harassed or anything by this landlord or whatever. So I think that's really an issue.
I think there's two segments, again, as we spoke before with mental health. I think there's two separate segments of this population. There are ones that can live independently, and there are those that can't live independently but don't want to be in a group home, that want self-direction. And those are two very different needs and two very different groups. And just going back to the intentional living, I would love for Commissioner Bear to put together a task force to go outside of New York State and visit the intentional communities that have been very successful and learn from those and bring those back to New York to see how we can do similar models here in the state of New York.
Agreed.
Yeah, I'm actually going to admit this. I'm actually been looking at some of those for myself. Like, I think I would actually do, that more communal, once my father passes away, essentially my caregiver, I don't know how not going to be able to be that independent. So I've been actually looking at moving out of state because there's nothing in New York State really that at least I know about.
One last suggestion on housing. I sat in on the DDAC call yesterday for an hour or so. Great committee, and thank you for that recommendation. I would love to collaborate with them on the housing issue because they address housing a lot in that committee at a much different level than we're addressing it at. So, and you have people on that board that are actually doing great work already. So I'd love to collaborate with that committee on.
We should also
Initiative.
collaborate. Oh, sorry.
Yeah, so I would love to see if we could come together with that committee on the housing issue.
Okay.
We should, sorry, one more thing. We should also have a talking to Arch Care because they're really looking into independent living for autism. So that's another thing we should just talk to and see if we can work together with that too.
Do great work. Any other thoughts on this area? We had suggestions around more independent type living situations, more intentional living with some flexibility for building community. We talked about more with collaborating with social services, and maybe we have somebody from the DDAC come and present or come attend our meeting and focus specifically on housing in a future meeting. Any other thoughts in this area?
Actually, I got a question. What's DDAC?
Question. Oh, we have a question. Yeah. Oh, the Developmental Disabilities Advisory Council.
Can I add? It's Mila Harrison from Department of Health. Because we've been talking a lot about actually both of these issues, access and housing. And do we need specificity around ages or populations? Do we need to think about housing for young adults who, their family is ready for them to move on, but what sort of supports do they need? What does that look like? That's not, a group home setting. Where can that be? How to have them be successful, whether they're going to school or working or, community involvement. And also, we're considering when people talk, I think mainly people talk about their own experience. I'm this age, this is my issue, but the aging population and the aging population of people with autism spectrum disorder with parents or caregivers who are aging and can't be there anymore. I think that's a really specific potential need that we might want to be thinking about as well.
It is. I sit here and think about Michael's situation, and I have others. My other business. I'm a wealth manager, and I'm trustee over a number of families that there is nobody after them, and the son or daughters live with those parents their entire life. That's a crisis that we are not prepared for, but it's a major crisis.
Yep. It's a great point. The statistics certainly back that up in terms of aging caregivers. So maybe it should be the focus of specifically that issue because aging came up in the earlier conversation as well. Okay. All right. So all right with the group, I'm going to move on to employment. And so what aspects of employment is this group interested in? What's our vision? Anybody else that we should be talking to or hearing from?
We should be starting talking to other companies, like companies itself, and why is it important to hire people with disabilities, because there's a lot of people in the employment won't hire people with disabilities because they're scared or not sure or like anything else. So I think we need to talk to companies or tell them that people with autism or a disability can work as a regular person who does not have a disability. So I think that's very important.
Agreed. Mike?
I'd say we need to look at what jobs we are lacking in the state. So like, for example, lifeguards, we have a lifeguard shortage. We have a shortage of EMTs. We have a shortage of firefighters. We have a shortage of, and some of these roles are great. Like speaking as an autistic EMT, it's protocol based. It's, it's short term. It's a great job that people can be trained to do. Part of it though, it's tough on the acceptance side and working with, I'll be honest, fire departments, EMS, they're kind of hard to work with if you have a disability. But that's something that we could look at and see if maybe we can create employment opportunities to fill these positions in the state that the state's generally lacking with, with appropriate training, appropriate coaching, appropriate support. But that's the catch, is that it needs that support network around it.
Yeah, I mean, I think about you have New York State Industries for the Disabled, which is sort of specifically targeted to give people who have disabilities more opportunity in very specific industries with generally state services. You've got the Department of Labor that we could ask to come here and tell us where are some of the major workforce shortages and where does it line up. But then what kind of training is required to put people in those positions, which could be a SUNY question of micro credentials to get them there. So it's a complex set of different agencies that in order for people to know where the opportunities are to get them there and have them be successful.
And the one comment I have there is that when we think about employment, we think about for pay, but we can't forget about the volunteer side of things. I mean, I think so much of this population would be wonderful on the volunteer side, and that's where it's greatly needed. And I think there should definitely be more training to help on the volunteer side. So not just for pay, but a lot of volunteers.
Yeah.
I agree.
Actually, I'm going to say that was with me because when when I'm in between jobs, I'm back to being a volunteer with the Red Cross. And we actually have a new volunteer who was fired from their state job for essentially autistic traits. And so now they're volunteering so that way they don't have a gap in their resume, but they're learning new skills. They're learning disaster relief skills, and they're actually considering going into a job working in emergency management.
And not only that, it gives them purpose.
Yeah.
I mean, that's the biggest thing about employment, whether it's
Yeah.
for pay or for not, it gives them purpose. It gives everyone purpose.
Purpose, skills,
Yep.
and it fills roles, I mean, that's what I did, and that's how I got to where I am now is because of my volunteer work.
So last April,
Oops, sorry.
no, go
I
ahead.
just wanted to say, it's Kate. I just wanted to say, talking about employment, another thing that I think is really important is to find those people that are doing the work that are autistic so that these young adults have someone to look to as a guide. So, for example, there should be way more businesses like mine where the person leading the charge is neurodivergent, so that when young adults come, they actually have somebody that understands them on a different level and with more nuance than, for example, an agency or the parent of someone who is disabled, because the nuance just isn't, it's not there. And I think it comes back to, where can we find spaces where disabled people are working and successful, that we can bring other disabled people to show those people as a model of like, hey, this is a way you can do it. One reason I think that's so important is because, like, for myself, I don't do anything before 10:30 in the morning. If they're talking to a neurotypical person, that neurotypical person might say, hey, if you want to be successful and if you want to have a job, you're going to need to work 8 to 5. No, you don't. So, like, again, it comes back to making sure that we're finding people with lived experience that can help us change these systems. These systems aren't going to change if it's neurotypical people that are making the decisions and deciding what the important things are that we're talking about.
Chris, you have your hand?
Or, sorry, or we can have them we can work together to make the jobs as mentorships and everything. I agree with that. Maybe we can like still talk to jobs and everything. I think the mentorship is a good idea. We got to figure out how we're going to do that. Make people understand that we can work and we're not what they think we are.
Yep. Thanks, Kristen. Any other? And Chris, you have your hand up? I think you might be muted. We can't hear you.
Oh, sorry about that. I just wanted to add that perhaps we could also explore just opportunities to educate individuals on supported employment programs that are available through Access VR, but also through OPWDD. And I was also just thinking about strengthening education about employment and navigating benefits. I know there's a lot of, just misconceptions and misinformation about maintaining employment, but also maintaining benefits.
Yeah, absolutely. Particularly as new work requirements are rolled out, I'm sure there's going to be a lot of confusion whether they apply to certain populations or not, and what those work requirements are. And the topic of navigation came up earlier in terms of access to services. So thank you for that, Chris.
I fully agree.
Okay. So I'm going to keep moving us along because we were going to have some open board discussion, but I do want to see if we can't get to at least one of the last two areas, which are health and wellness and cross-system collaboration. So if it's all right, I'm going to move to health and wellness, which was also, it was in the top 5. It wasn't as much as the 3 we just spoke about, but it made the top 5. So what kinds of health and wellness and healthcare are you interested in talking about? What's your vision? And is there anybody else we should be talking to or hearing from? Okay, Mike.
I mean, my thing is, it goes back to access. How do we access it? How do we navigate it? I know there's like Medicaid Navigator, stuff like that.
Mm-hmm.
And I think it's really just, there's a pretty robust healthcare system. It's just tough to navigate.
Yeah.
Like, that's kind of my 2 cents on that one.
Yeah, healthcare is definitely tough to navigate. But generally health and wellness, I mean, it's poor across the board, poor outcomes generally for people who have intellectual and developmental disabilities. And I think just raising awareness and then trying to put in place different interventions that can help people with understanding what it takes to be healthier and well, and then learning about how do you access those services. Completely agree.
And I guess also I would, now I think about it, I would like to add too, like, the mental health side, and that kind of feeds into that awareness and acceptance. Kind of really making sure that people feel like, they belong. That's something that we can really make, here are some, and not having that access to services does take a very big mental toll on people, and the navigation, and just kind of that feeling of being beat down all the time.
Mhm.
So I think, that's something where, that it kind of all comes together on that with all of this, even the cross-system collaboration, having that more open, transparent system
Yeah.
would just kind of, all ships will rise. If you're clinging to driftwood or in a multi-million-dollar yacht, having that better access, it will just bring everybody up.
Yeah, and this could be a potential cross-agency collaboration, whether it's Department of Health and learning more about their health and wellness programs and how OPW can take advantage of that, or the Office of Mental Health. There's such a connection between physical health and mental health, maybe learning some more about what's available.
And don't forget the other nonprofits and stuff like the Y. I think the Y
Yeah.
would be a major, and some of those other groups be a major part of that. And also too, the DEC, Office of Parks, outdoor recreation.
Yep,
I
absolutely.
know you can get $25 to pay for a year for the gyms, for the New York Park gyms. You just have to show your paperwork that you're disabled, just so you guys know. Also, I think when we talk about doctors and everything, I think acceptance or just talking to the people. 'Cause I have experienced that doctors talk to your caretakers or your guardians, not the person who's getting checked up on. So I think that's another thing we need to work on. People talking to the patient, not the caretaker or the mother and father, you know?
Yep. I agree. Okay. I'm just looking at are there any other comments on health and wellness?
I just wanted to add like more information on how to utilize self-direction budgets to support access to those gym memberships and health and wellness classes and all of those supports that are available for individuals.
It's a good suggestion, very concrete one. Because yep, I don't know.
I
Okay.
agree.
Yep. Okay, I'm just looking at the time, what else is on the agenda in terms of open conversation and public comment and all of that. And I think I'm gonna table the last one because I think it deserves not to be rushed, which is cross systems collaboration. So a lot of these things that we talked about in the first four would benefit from cross systems collaboration, but I'd also like to table it because I'd like to have, I think there's a few agencies missing today. I'd like to have more robust attendance by the agencies when we do go to talk about it. So if we put it as more of an agenda item on the next meeting, that's my preference, unless somebody's has something burning they want to say about cross systems collaboration right now. Any other thoughts on that?
I think that's fine.
I appreciate that. Okay. Yeah, so we wanted to open it up for general comments or thoughts from the board for a few minutes before public comment.
Trying to find it. I got a quote from Josh that he asked me to read, but I'm trying to get it in my text feed. So,
Okay, well, we can come back to that if we want at the end of the meeting.
It's Mila again. We've been talking about lots of really intense specific ideas. I think we still need to prioritize. So we can't do even the four that we talked about, like tackling that in this group we won't get anywhere. So I suggest we also decide how to do the most feasible of the ideas first, if we can get to that, or within all the ideas. There were so many really good ideas presented, but within those ideas, what will move forward, what doesn't need, legislative input, what doesn't necessarily need a budgetary item, what can be done with resources we have now, or because it's in some other spaces or committees, or is really pressing. So I would just put that out there. But I really do think this group we really should be focusing on something. It will help us all. I think we'll get better attendance. I think if everyone knows this is what we're working on, and here's the things that are coming, people go out and do something, come back together and share what they've learned, I think might be helpful.
I think to that point, for instance, Josh did a great job with the flag. He kept everybody on point with that, right? And we were consistent with it. We didn't come one week and then we forgot about, or one quarter and forgot about it the next quarter. I think to your point, we have to do the same thing and have some consistency and see it to from beginning to end instead of forgetting about it. So I think that's a good point.
I think it's a great point. Yeah, so I think for our April meeting, what we should do is we'll finish the conversation on the cross systems. And if we could have some criteria, and you mentioned a few of them, to help us with the ranking, how feasible is it? How timely is it? Perhaps impact might be another criteria that we use to help us rank them. And then we keep the running list so that we can sort of go through and check them off over time and not get lost. I like
Courtney,
that.
this is Rachel. The only thing I'd add to that is some of the things that were mentioned are being really actively worked on at the Developmental Disabilities Advisory Council, which is another advisory council. And so something that Caitlin and I can do between now and April is write down everything everyone said, right? So we can take a robust sort of notes and collection. And then also look through and see, is this a topic at the Developmental Disability Advisory Council where there's a lot of in-depth focus on it, and this focus could be better directed to what they are not focusing on. Up to you all, but we can do that sort of back end work and present it.
I think it would be really helpful to sort of see the alignment and where the gaps are. Absolutely. So we're not duplicating. Yep. Mike?
I would say if we could develop like kind of like a, in emergency management, we have an action plan that
Yeah.
has the priorities and then the specific objectives, what order we're going to do them in, who's responsible for them. Like if, that might be a good format. And I'll be honest, that might be something that maybe we ask the incident management team planning division from Homeland Security to help us with. Because planners love doing that stuff.
Sure. Sure. Well, I mean, we'll take whatever free resources we can get.
Speaking as a planning section chief, so.
Yep.
I did notice that Commissioner Bear was at the DDAC. Is she at every one of those?
Okay. Great. Well, really good suggestions today. Robust conversation. Do we have anybody lined up for public comment? Checking to see if anybody's here for public comment online.
Well, actually, Josh he asked me to read a quick statement about the flag and
Sure.
an event. So the neurodiversity strength flag is more than a flag. It's a symbol, a calling card. And for too long, a vast majority of neurodivergents of all types have felt a sense of hopelessness. We feel that we are in a world that is not designed for us, not made for us. We lose too many of our own due to this. The flag, the lighting up of the state must be seen nationwide. We have in our state the greatest city in the world has ever seen. We have in this state the stage the world looks upon, New York City. We truly want this to make an impact it can and to do justice to the greater neurodivergent community. We must hold the ceremony in Manhattan, for only in New York City will the eyes of the world watch and listen to what we have to say with our voice, our movement, our flag. We must hold a kickoff event in New York City. And that's from Josh, the creator of the flag.
Great. Appreciate that. Yeah. Some of us had gotten that email, so appreciate you reading it.
I'm just going to add, not that I know how this happens, but maybe you all know this. The Empire State Building has colors that people, I don't think they pay, I'm not sure, but there are And it depends on the day, and every day it's a different color. I used to live where I could see it from my apartment in New Jersey. And I mean, that would be, if you got one day on the Empire State Building, you could probably get a press event out of it if you needed.
And also too, actually, you could throw the switch. So they actually you can do a ceremony there where if it's your day, like the Red Cross, when we do
Right.
light up red,
Right.
they'll actually go and you can throw the switch and it's on their Instagram, their Facebook. Same thing with ringing the stock market bell. So that might be something we also explore during that month as a way to kind of bring that.
That's
and-
actually not that difficult to do.
Yeah, no, it's very easy to get. But the thing is, we just need people to show up.
Well, I think what we could do is we could make a request that the commissioner write to whomever that is that's in charge of the lighting of the Empire, that we could, for World Autism Day, that that we make that request, because there may be other people who want that day lit for a certain reason, but yeah.
Yeah, I think that's something we talked about at a previous meeting, was ensuring that we reached out to like Empire State Building and some of the other private entities about the lighting for April.
Okay.
Yeah, I mean, if we want, I could take on the stock market thing because I've done that with the Red Cross. So
Yeah, sure. Sure.
3 public.
Okay, we have 3 public comments, so why don't we turn to first one?
Yeah, so we have 3 people who have raised their hands for public comment. We had a really robust discussion today, so a little less time for comment than normal, but if you can always submit something in writing to ASD Advisory Board at opwd.ny.gov, and I can put that in the QA so people can see it. All right, so first up, we have Quentin. As a reminder, this is an opportunity for public comment. We will not be answering any questions today, but we're excited to hear from you.
Go ahead, Quentin.
Oh, thank you. I have 3 minutes. I don't need that much time. But based on the news recently with the updated childhood vaccination schedule, I just want to know how our state, because I know that was a federal mandate, but I wanted to know how our state will be implementing it. So specifically with my children in school, I know schools don't make medical decisions, but they enforce compliance. So I just want to have an understanding on what kind of clarity and how will it be updated in guidance, and how will that guidance be communicated to the school nurses, administrators, and enrollment staff, so families like mine are not incorrectly flagged or denied access to services, whether it be in school or even whether it's be with our doctors, to get these services here, knowing that it's changing on a federal level. And this will just keep things procedural and not medical. So I'm not here saying anti anything, but I do want to be compliant, but knowing that the rules have just changed recently this week, how is that now being addressed and implemented so we can all be on the same page, knowing that there's more choices? And that's all. But thank you for all that you do. I really appreciate it.
Thank you, Quentin. That specific issue is outside the scope of this board, but I'm sure guidance will be coming out from the Department of Health. Oh, wait, next up we have Roseanne.
Roseanne, go ahead. Lost her.
Donald, you should be able to unmute.
Hello? Oh, okay.
All right, if there's anyone else that would like to issue public comment, please raise your hand. If not, a minute.
Give people a minute to raise their hand. All right, so appreciate the comments that we did hear today. Really good discussion. I think we've got our agenda for the for the next meeting, which is going to be April 22nd. And then the other meetings this year are July 22nd and October 21st as of now. So if you have any major conflicts, let us know, but looking forward to the next meeting. It's a good start for 2026. Thank you, everybody.
Thank you.
Thank you and Happy New Year.